And now I give the floor to Ms. Amany Qaddour. You have the floor.
Hello, good morning. Thank you, Mr. President, for inviting me today, and thank you to the members of the Security Council for having me. I'm here today on behalf of Syria Relief and Development as a humanitarian agency that's operated on the ground since 2011, so essentially since the start of the crisis. And we've had the privilege to serve Syrians predominantly through health, protection, and shelter programming. And I think we've really seen the evolution of the crisis play out over 9 years now, approaching its 10th. And we see that many Syrians, as Mark so eloquently emphasized, have been forced to live a life without dignity out of sheer desperation. What I'm hoping to highlight today is a few things, one being the COVID-19 pandemic, essentially now a crisis within a crisis. And in addition to that, some of the underlying health implications and ultimately the key operational challenges that we face as a humanitarian agency. So in terms of COVID-19, we're really being challenged in an entirely new way. And I don't think this is specific just to Syria, as we see more advanced nations struggling. But Syria is uniquely vulnerable considering how fragile its health system has become with the deterioration of the economic situation, many being on the brink of starvation, mass displacements, and some of the most extremes we've seen in weather. We're having tremendous heat waves across Syria right now. And also this past winter, which we certainly anticipate for this winter as well, is flooding and snowstorms. So with these conditions as the backdrop, this has really shaped sort of our COVID response and the need to constantly plan around uncertainty. As an example of this response, we have an incredible partnership with the World Health Organization, where we serve as the lead agency for infection prevention and control, as a very key pillar under the emergency task force, along with many other vital actors in this health response. But despite these tremendous efforts, there are still challenges, there are still shortages, as we've seen globally, and particularly in Syria, the shortage of ventilators, ICU beds, and personal protective equipment for aid workers. And to add to this, we've really, obviously, with the fact that there are hundreds of thousands of people, if not millions, living in precarious housing situations, these conditions simply don't allow for proper social distancing or self-isolation or adequate hygiene measures for that matter. And we see cases on the rise, and we know with this pandemic in particular, there's been absolutely no consideration or respect for geographic boundaries. We see cases on the rise not only in Idlib, but in Hasakeh and Damascus, and I think, particularly in northwest Syria, many of the cases have affected healthcare workers. And as a region that's already dealing with a shortage of skilled workers, human resource capacity is really something that's critical for this response. And I think this particular point really highlights how fragmented the health sector and infrastructure in general have contributed to the tremendous needs, both from a health standpoint and in terms of key services, because we know that negative health outcomes don't emerge in a vacuum. And that's why, beyond the initial focus in the early stages of the crisis on emergency and trauma services, there's been a massive expansion of the definition of life-saving services and a push for health system strengthening. And I know Germany in particular, this has been a focus for them with GIZ's investment in the health directorates, for example, or as many other donors have really looked at health sector strengthening, such as USAID and DFID, and of course the EU's ECHO. And in our case, and I say this both as a humanitarian and a public health practitioner, there's been a need to look at healthcare as a continuum and include provisions such as primary and community health, rehabilitative care for the massively growing population that has now lives with disability, and of course mental health, given the immense traumas that so many have endured, including the rise in depression, post-traumatic stress disorder, and suicide ideation. And this really applies both to the people we serve and the aid workers that deliver these services. And that's why there's really such an obligation to protect our aid workers. And that's why we also put the onus on our partners and on the security itself to share that risk with us, to protect not only the people, but the aid workers themselves, many who have actually sacrificed their lives in the process, like Dr. Hassan Al-Araj of the Hama Health Directorate, or Imad Zaytoun, for example, who worked at our hospital in Arwaja. They both died very tragic and violent deaths as a result of attacks to healthcare infrastructure. Another large part of this risk sharing, of course, is facilitating our access for service provision. And the most recent cross-border resolution has certainly impacted this level of access. I think specifically in terms of Bab al-Salam and the access we had, which is critical for the work we do, means that we're adding more burden now on our aid workers to deliver to more distant and hard to reach areas. And beyond service delivery, I'd particularly like to emphasize the coordination mechanism. As I said, key partnerships from technical agencies and partners, including the WHO, UNFPA, and UNICEF, among other key bodies, for example, have been vital for this response. And before I closed, you may have noticed I didn't emphasize health services specifically for women and girls in the healthcare continuum and their unique vulnerability to COVID. But that's because I'd like to give singular and explicit attention to this group that's endured some of the most harrowing circumstances in terms of neglect from a health standpoint, and also in terms of continuous exposure to sexual and gender-based violence. With the thousands of displaced this past year, we saw women give birth outside under trees without access to health care, when thousands were displaced and our aid workers were on the move. Excuse me. Or in the case of girls, with the practice of early marriage, as young as 11 or 12, as one of the most extreme forms of coping for families and girls who lack alternatives, as Mark said, in the form of education and a simple means of living. And I think it's tempting to blame such practices on sociocultural norms or other ideological issues, but I ask you to consider the complexity and the deeply rooted factors that have culminated and led to these practices. We see this in many contexts. It's something we struggle with at a global level, but we most visibly see it within the context of conflict. So I really ask you to uphold the need to provide such life-saving services, of which the response to such forms of violence certainly qualifies. And I'll just conclude with just a few fundamental issues to ask is the continued need and the sustainability of humanitarian service provision, continued access, and the prioritization of humanitarian needs above all else, particularly because the decisions made in this chamber have shaped the lives and the fate of millions. And thank you for this opportunity.
Okay, I thank Ms. Qaddour for her briefing.